lecture is titled Unmasking Anemia in Chronic Kidney Disease, and I would now like to invite Dr. Rohit Amarudana to introduce our speaker for the day, Dr. Prabash Hathurusinghe. Thank you, sir.
Good afternoon, everybody, and thank you, Dr. Taraka. And you all are welcome to today's session organized by Mahiyanganaya Clinical Society in collaboration with the GMOA branch Mahiyanganaya. Today's speaker, I think everybody know Dr. Prabash Hathurusinghe, consultant physician of Mahiyanganaya based hospital. Before introduce today's speaker, let me to thank, because I think most of you know, because I work here in this hospital for 2 years and 3 months as a consultant physician, and this is my last day and I am leaving this hospital, and because that is normal, we are coming for transferable appointments, and we have to go back to our whatever the places where we our hometown. So anyway, I am planning to leave this hospital today, and today is the last day, and I will report duty in my next station, Gampala based hospital. I take this opportunity to thank of my everybody work with us together in the clinical society. Especially I would like to thank my co-secretaries, Dr. Kaushal, and he is not here today, Dr. Rasika and Dr. Kaushal, and also Dr. Chintaka is our secretary, and they are tireless work, and they are pillars for this society, and the bring up to this level, and lot of lectures we did, lot of academic activities we did. Effortless, tireless work is the why we did this much of improve our societies going up. And also I would like to thank our council members. I don't want to say them by name, and all council members together, and that is why we have to really successfully we did a lot of lectures and academic programs. And also not only the council members and all other team, they are not council members, but my house officers and all medical officers, and I don't want to tell by name, but everybody helped, and that is why we did a lot of very interesting and important academic programs by Mahiyanganaya Clinical Society. Also, I would like to thank GMOA branch union members and council and everybody, because they are behind and they support us continuously. And I want to thank my consultants, all consultants, Dr. Prabash and Dr. Lochana, Dr. Sumudhi, and our consultant pathologists all together, and everybody is not here. So we work together, and a lot of our surgeons and EOGs, everybody help a lot, and they have continuous support, and that's why we were here. And also all staff, all medical officers working in this hospital, all members of the society, and your support and your participation is appreciate. And so I take this opportunity to thank everybody, because you are here. That is why we did a lot of important academic programs. And also I would like Dr. Chintaka, he is always here and supporting us for the photography and everything, not only the photography. So he is a very he's a support for this society activities. And also today I would like to thank sponsors at Astron Pharmaceutical, and he twice sponsored for this sessions this year. So I take this opportunity to thank today's sponsors also, Astron Pharmaceutical. So let me to introduce today's speaker, my friend, my colleague, Dr. Prabash Hathurusinghe. Dr. Prabash Hathurusinghe, MBBS calendar year 2013. He passed MBBS with and distinction in medicine, and he did his in Colombo University and PJ. and his overseas training at Flinders, India. He is a board certified consultant physician and specialist in general medicine, and he published research papers, research articles in peer-learning journals, and his special interest in topical medicine and renal medicine. He is going to talk on anemia. Invite Dr. Hathurusinghe to deliver the lecture today. Thank you.
Thank you, Dr. Rohita, for the kind introduction. And good evening, Clinical Society, and thank for my dear colleague consultants and all the medical officers to participate this occasion. So I selected this topic, unmasking anemia in chronic kidney disease, because of few reasons. So when I start practicing as a consultant physician, especially in Mahiyanganaya cases of chronic kidney in this area, as well as anemia. So most of the patients, regardless they are presenting complaint, backgroundly they are exercised to digging deeper of this anemia in chronic kidney disease, as well as because of the chronic kidney disease, anemia is masking. There are several important other causes are masked by the term chronic kidney disease. So this is something, some small lecture regarding the few other causes and exploring more regarding the anemia of chronic kidney disease. So this overview, so I will briefly talk about prevalence and types of anemia in CKD and certain diagnostic criteria and testings. Especially the iron deficiency in CKD is very much common, and more than 90% of the cases we are handling. So it's a few introduction regarding the diagnosis as well as how to manage this oral and intravenous iron and EPO and their monitoring, and some research papers recently published regarding new therapeutic advances of anemias regarding HIF and SGLT2 inhibitors. So as I told earlier, anemia is a very frequent complications of chronic kidney disease. So it is more commoner when the CKD is progressing, when the GFR is declining, the prevalence of anemia is more. In other words, early stages of anemia, there may not be anemia, but when the eGFR further declining, CKD stage is more progressing. So especially if it is below 60, the anemia is starting to appear and they become more complicated. So usually in prevalence, recent data suggested 60% of having anemia as a complication. So when they become more advanced and become dialysis dependent, the percentage is rising up to 90%. So it is also, as you can see, it's declining the level of talk about anemia in CKD. So you know that the chronic kidney disease has several complications. Not only the anemia, they can have a high risk of cardiovascular diseases, CKD, bone diseases, and several other complications. One of the complications is anemia. So when we talk about the anemia in CKD, so during our medical student time, it struck to our mind is mainly it is mainly due to decreased erythropoietin production. That is the hallmark of anemia in CKD. But if we explore more some other causes of anemia, so other than the decreased erythropoietin production, there are so many other causes. So this is very important, because most of the CKD patients are having very poor appetite, they are chronically malnourished, and their gut wall has small edematous because of the edema, so the iron absorption and iron intake. So they can have very high risk of iron deficiency. They are having high risk of blood loss, because the uremia can cause small damages in the intestinal and the stomach mucosa. Then there's a chronic blood loss, and because of the uremia, the red blood cell survival time also very low, and other comorbidities, comorbid diabetes, hypertension, conditions, right? And also the bone marrow suppression by the uremia and the bone mineral disorders. So certain medication, like most of them are having the enorphil or losartan early stages of CKD, so that directly it inhibit the bone. It's like it's directly related to decrease erythropoietin production. So there are a few papers and researches are done, the ACE inhibitors, how they contribute to anemia. So they have found that it directly affect the decreased erythropoietin production. So most of them we ask to cut down when the CKD advances, cut down proteins, and also they are high risk of developing vitamin B12 and folate deficiencies. Other one is the hepcidin level is very high. So we know that the hepcidin is very much important for iron regulation. So it has negatively correlated. So when the kidney function goes down, the hepcidin clearance levels goes down. So when there's a high hepcidin level, that directly affect the intestinal iron absorptions and bone marrow responsiveness to erythropoietin. So there are few other causes. So other than what we know, commonly known as decreased erythropoietin production, there are few other causes we all together as umbrella that will contribute to anemia. So when we consider some, I told some few causes earlier, there are few causes potentially easily correctable, and there are some other causes are partially or potentially correctable, some of them are impossible. So even the patient is having CKD, it doesn't mean that he doesn't have any other, he's not having any other comorbidity. So especially CKD with anemia, patient absolute iron deficiency is very important, easily correctable, and other mineral deficiencies like B12, folate, concomitant hypothyroidism, and non-adherent to treatment, ACMA. Some other causes like the high risk of chronic inflammatory condition with recurrent infections, some bleeding, upper GI, lower GI bleedings, some malignancies, malnutrition, red cell aplasia. So these are partially correctable or potentially correctable if we detect and implement early. Some of the conditions which are associated, not directly associated with the CKD, but patients are anyway, if they develop these disorders like bone marrow disorders, hemoglobinopathies, so this anemia with CKD may not be fully correctable or reversible. So when you come to anemia in CKD, so I told few causes. So typically when we categorize anemia as a microcytic, nomocytic and macrocytic. So typically anemia in CKD, typical picture is a nomocytic pneumochromic anemia. So it will happen due to reduced red cell production versus reduced red blood cell lifespan. So what happens is the typical picture, as I told, erythropoietin deficiency. What happens is when there is a hypoxia and high altitudes and anemia, so they will stimulate erythropoietin production. So gene transcription, the hypoxia induced transcription factors are important to bone marrow to produce kidney and liver to produce erythropoietin that will directly stimulate the bone marrow. So HIF2 is primarily responsible. So the stimulating factors are the hypoxia. So the production capacity of erythropoietin remain significant latter part of CKD. So when there is a progression of the CKD advance, the production capacity of erythropoietin is significantly impaired, and also the poor response of this erythropoietin chronically, reduction of the hemoglobin. That is a classical, that is a common problem in chronic kidney disease. So when we consider how are we going to diagnose and evaluate anemia in chronic kidney disease, so we know that most of the patients in the ward we investigate, sometimes they found to have elevated serum creatinine. We confirm with the ultrasound abdomen to have a chronic kidney disease. Then depending on EGFR we categorize. So when and how to start evaluating the anemia. So in adults and children more than 15 years, so their hemoglobin concentration less than 13 males, less than 12 in females, we need to start evaluating the anemia. So when we consider CKD stage 5, where they are only close to their dialysis, so the hemoglobin concentration falls below 8. And if below 8, and also patient are non-dialysis untreated, whereas CKD patient who are non-dialysis, they have higher. That's why in stage 1, 2, 3 their hemoglobin concentrations are initially high, but when they progress to stage 3 or 4, their hemoglobin concentration can still falls below 8. So then if they are found to be anemic, should be evaluated for potential causes other than the erythropoietin deficiencies. So there are certain criteria. So we easily categorize people who are non-dialysis, on hemodialysis and peritoneal dialysis. These are the three
broader categories. So CKD patients without anemia, so hemoglobin clinically indicated, if they have usually do annually, if the eGFR is more than 45, at least twice per year if they have less than 45. But patients with anemia, this is not being treated with erythropoietin, so then they have to do monthly assessment with eGFR 45 and less than 45. So hemodialysis patients, we have to evaluate for anemia every 3 months, at least 3 months, peritoneal dialysis 3 months. So we can get a rough idea. The summary is we can refer this at any time, but we have to have some idea. So when the patient is having the CKD and anemia, we don't not neglect it, and we have to do some investigation, find out the cause more frequently. So initial evaluation, we can do a full blood count as cause of other causes of anemia. So we can see the red cell indices, whether we are dealing with a microcytic, macrocytic, or nomocytic anemia. So we can do some retic count to exclude any underlying hemolysis. Then very important tests are serum ferritin level, serum iron, transferrin saturation, and PIBC. So vitamin B12, folate, and stool local blood. These are the initial pack of evaluation of anemia in CKD. So in our setup, I think we can largely depend on serum ferritin and full blood count. So getting PIBC, transferrin saturation is far more difficult, and so we usually go with the ferritin and full blood count. But in ideal setup, we have to always go with these few tests and do some stool local blood. They are high risk of GI bleeding because of their cut down of lot of animal protein. They are high risk of vitamin D2 and folate deficiency as well. So in summary, so anemia can be attributed to CKD if GFR is less than 60. So if the eGFR is less than 60, so we can say this anemia is likely to be the cause of CKD. And if it is less than 30, that is less than 45 in diabetes, always we can consider CKD is playing a part of anemia. So in the early stages, if the patient is having CKD but patient is more anemic, then our concentration should go to evaluate for potential other causes as well. Right? So always go in the macrocytic, microcytic, and nomocytic way. So this is some simple case. So we got a 58-year-old male who is having serum creatinine 3.5. eGFR is 18, that's the latter part of later stage. So found to have a hemoglobin 8.5, MCV is 60, and transferrin saturation is 18, and ferritin is 80. So if we get this kind of a biochemical picture, so we know that this eGFR is more advanced, so he's having a part of CKD as well, but we expected MCV to be nomocytic nomochromic with iron stores are fully saturated if it is purely because of anemia due to CKD only, but we know that MCV is significantly low with the iron stores are quite depleted. So then we have to evaluate potential underlying iron deficiency. So when we consider this iron, the hepcidin is very much important as a role of iron absorption. So when there is a CKD, the clearance of hepcidin is very much less. That will reduce the gut absorption as well as macrophages to recruit usable iron. So that iron is very much important in the hemolysis, so hemopoiesis. So the iron deficiency we can expect most of the patients with advanced CKD. One of the mechanisms is hepcidin, other one is the poor oral intake, malnutrition, and other conditions as well. So like in previous case, so iron deficiency among CKD is a very common condition day to day we encounter. So usually there's this for two reasons. One is the reduced absorption capacity, plus there's iron loss as well. So there are two terms here: absolute iron deficiency. The second one is adequate iron status and functional iron deficiency. There are three terms just to be familiar. So absolute iron deficiency means completely diminish or absent bone marrow iron stores. So that is gold standard is a bone marrow biopsy is a gold standard, but in practical situations we use most of the biochemical tests to detect absolute iron deficiency, but keep in mind the gold standard is a bone marrow where you can see absent marrow in the body. So then we go for biochemical test, especially the transferrin saturation. This is a calculation. So if it is less than 20%, and with serum ferritin level, patients who are non-dialysis less than 100, less than 200 among hemodialysis patients. So in previous case, we know the transferrin saturation is 80, serum ferritin is 80. So it is having this absolute iron deficiency with the CKD. So there are, we can get several values. For example, serum ferritin value less than 30. We can assume that severe iron deficiency, so we can get a highly predictive absorption. So if it is less than 20, it is absolute deficient, but if it comes to a less than 30, we can predict the severe iron deficiency. Sometimes the serum ferritin level more than 300, we can assume that most of them have a normal bone marrow ions. Other investigations we are not routinely done here. So one is the hyperchromic red cell count percentage and reticulocyte hemoglobin content. So these are the two investigations we may not be very much familiar, but that is important. I said the reticulocyte hemoglobin count indicate how iron incorporated in the retic count. So that is useful for guiding iron treatment therapy. And so erythropoietin is stimulating an iron treatment. When we evaluate for iron treatment, to evaluate the progress, we can get the reticulocyte hemoglobin and percentage of hyperchromic red cells. That's making the sensitive the long-term average functional parameters. So these two tests are not much replaced because of the clinical decisions and other. So we can symptomatically and other parameters are there. So not much use for, but it's very much important to investigations. So adequate iron status means transferrin saturation more than 20, but serum ferritin is range between 100 to 500, 200 to 500 in hemodialysis patient. We know that there is some adequate iron status. So there's another one called functional iron deficiency, where the opposite one. So we get the transferrin saturation less than 20, but the ferritin levels are very high. So that is important, whether the functional deficiency may be a part of, and we know that the ferritin is a marker of chronic inflammation. So when the patients are having CKD, it's a condition where the high inflammatory condition in the body, so the ferritin level expected. We know that the anemia of chronic disease, one of the diagnostic marker is their ferritin levels are very high. So this is saturation less than 20, so that is maybe a part of anemia of chronic disease or erythropoietin deficiency. So we give some iron and then do the repeat test and see whether there is a chronic disease or some underlying iron deficiency. So this is just to refer. So the summary is indication for iron is very important. So patients with non-hemodialysis, hemodialysis and peritoneal dialysis. So first we have the patients who are not dialysis, you can use oral or IV treatment. Right? So if patients are on hemodialysis, very important parenteral iron rather than oral iron. And if the patients are peritoneal dialysis, we go for intravenous is better than the oral iron. So indications are, as I told you, transferrin saturation less than 20 and less than 100, we know that's absolute iron deficiency. So, but most of the patients who are less than 30 and ferritin less than 500, we usually do not start, we usually recommend iron treatment, but if they have more than 20 transferrin saturation, if they are symptomatic, then we can observe the patient and see. But if they are underlying heart failure or ischemic heart disease, and we have to individually assess. So adequate iron status, as I told you, saturation more than transferring more than 30 with more than 500 ferritin level. But in hemodialysis patient, so definitely absolute iron deficiency, we have to start treatment. Patient hemodialysis who are hemoglobin less than 10 and target less than 30 and ferritin less than 500. So this is a reference we can use. The summary is the important take-home messages is non-hemodialysis patient we can start oral and IV. Hemodialysis patient, definitely a parenteral one is better than, and intravenous for peritoneal dialysis. All patients with absolute iron deficiency, definitely we have to start iron treatment, but individually assess other comorbidities, whether the patient has adequate in between adequate iron store. For example, transferring less than 30 and 500 in non-hemodialysis patient, we do not start if they have a adequate saturation more than 30 and ferritin more than 500. These are some values we don't need to get confused, but we can always refer and get the idea and individualize, right? So this is some when we start iron, whether we are going to oral versus IV iron, so there are certain guidelines, that's what they put. So the KDIGO guideline, NICE guideline, European best practice guideline. So the KDIGO guideline says, I told earlier, intravenous therapy is better in hemodialysis patient. NICE guidelines says oral line for individuals who are not on erythropoietin stimulating agents. So European best practice suggests IV is optimal route for patients, practical reasons, but oral line may be considered not on dialysis. So the problem is giving dialysis patient or peritoneal as oral line is their absorption is poor and they may not be tolerant because of the uremia symptoms are there. So this is some types of iron, IV iron. So we have Venefer is the one we commonly use, iron sucrose, but other than that there is a sodium ferric gluconate, low molecular iron dextran, ferric carboxymaltose, iron isomalt, and all. So these are just to refer their concentration, elemental iron, how much, and all. So when how to start IV iron, so patients who are in peritoneal dialysis and non-hemodialysis, you can start with the 200 day 1, 400 as an initial one. Hemodialysis, we can use 200 milligram for 5 doses. So this is the indication I told in that box. If the patient have a severe iron deficiency, we can go for IV iron. Severe anemia, HB less than 7. Risk of ongoing blood loss, such as patient has a chronic GI blood loss. Previously tried some oral irons, but they have a side effects, intolerance and gastric. Previously not responded to oral iron, and that depends on the availability of venous access as well. So when you consider oral iron, so daily administration goes elemental iron approximately 200 per day, 3 times doses, ferrous sulfate 325, 65, and so ferrous fumarate and ferrous gluconates are the common associated, but other than that they can have, there's a new drug called possibly the phosphate binder, ferric citrate and sucroferric hydroxide. So other than correcting of anemia, starting iron in a patient with a CKD, they have studied few potential benefits. One is patients on dialysis giving iron treatment that cause reduction of congestive heart failure. So they have studied for patients on dialysis some additional benefits. So reduction of occurrence of myocardial infarction, yes, but other conditions which are limited studies and not being studied. So giving patient with iron, patient who have other comorbidities like ischemic heart disease and heart failure, so giving iron has some other additional benefits as well. So what are the increased risk harm in iron administration? So is there anything they have studied, but the risk of recurrent infection, other cardiovascular, CKD progression, anaphylaxis, especially with the IV iron, there's some risk of having anaphylaxis, but other than they are not proven anything harming, any side effects giving oral or IV iron. So that has certain benefits of mineral bone disorder as well. So the oral iron and IV iron. Right. So then once you diagnose patient is having the chronic kidney disease, you found a patient be anemic, you did some basic tests and found they are iron deficient. So you start oral or IV iron depending on the clinical scenario. Then how to evaluate the iron status. So you can do, if you start on oral iron, at least 3 monthly. Intravenous iron evaluate after the therapy. So we know that doses, so we can repeat sample and typically 1 month following the initial dose IV. Right. So that is a case where patient is diagnosed to have a CKD and found to be anemic. So this is some of other cause. This is a typical picture where the 67-year-old female with CKD referred from local hospital. The creatinine is 4.1, hemoglobin 8.5, where the patient is having adequate iron stores, as I told her, is transferring 28, serum ferritin is 400. So what is that is? the erythropoietin stimulating agent. So before starting the erythropoietin stimulating agent, we have to address all the correctable causes of anemia, including iron deficiency, other inflammatory condition. So then they can have a balanced potential benefit. So when we start ESAs, if the patient is very much anemic, very much symptomatic, we potentially do blood transfusion in our ward setup and daily setup. So if we start correctly ESAs, then they can have reduced need for blood transfusions and other anemia related problems like stroke, vascular loss, hypertension. So ESA reduce need for transfusion as well as improve quality of life. But before starting, always we have to correct all the correctable causes of anemia. So indication for ESAs are most of the CKD patients have having hemoglobin less than 10, providing saturation more than 25 and ferritin about 200. That correct the absolute iron deficiency. So there are two ESAs. One is short-acting EPO alpha and EPO beta, and long-acting DABI and methoxy polyethylene sera. So this is one of the formulas, but so EPO alpha and EPO beta, which are short acting, we can do 20 this weight adjusted dose 20 to 50. So ideally we have to do 3 times per week. So they say in practical situation we do weekly or twice weekly, but if we do more frequently, they found it would be more efficient. But this one is not much practically using. DABI is 0.45. We can do weekly or 0.75 every 2 weeks. This sera 0.6 every 2 weeks and every 4 weeks. So we can, most of the time we use EPO and DABI in our setup. So this is roughly the practical guideline. Practically we say weekly 50 to 100. Weight for weekly, DABI 60 to 200 every 2 weeks or 4 weeks. Further titration depending on the HP response. So for example, most of the patients are between 4,000 to 10,000 subcut weekly. So 10,000 or 20,000 every other week, 2 weeks. These are the common doses depending on their body weight. So as I told you, so if it is a weekly or less frequent dosing has been more effective and safe. So but in practical situation, it is we go for weekly or twice daily. So the problem is we have to be the lowest possible dose, weight adjusted lowest possible dose to maintain because of risk of stroke and other cardiovascular diseases, MI and all, right? So increasing dose should be not be made frequently. Usually we give at least 1 month and see the response. Then depending on that we have to increase the dose. So usually, so when the hemoglobin target, if hemoglobin becomes 11.5 and above, then the dose should be reduced approximately 20. So our target is so patients with end-stage renal failure on hemodialysis hemofiltration, we can do subcut or intravenous. So subcut administration for all non-hemodialysis patients. So the target hemoglobin is right, ESA target. So we give 1 month when we start EPO. So we get a 1 month 1 to 2 gram increase is a target. So maintain hemoglobin around 11.5, but it should not increase above 13. So these are the roughly values. So we start EPO after correcting all the correlates. If hemoglobin less than 10, then we start weekly or twice weekly, and HB target in the first month is roughly 1 to 2 increase, and maintains hemoglobin around 11.5 to 12, roughly 12.5 or 13, but we have to reduce the dose when the hemoglobin concentration goes more up. So there's a high risk of cardiovascular event. Right. So this is some trials going on. So depending on that, the target hemoglobin regarding mainly the hemoglobin target. So they all discuss about 10 to 13 level and higher rates of thrombosis. If the hemoglobin, so summary of this chart is when we get the EPO and get the hemoglobin, if the hemoglobin levels is more higher values, it's 14, 13.5, there's a high risk of thrombosis related cardiovascular events. But if they maintain around 13 to 11, that is improve the quality of life. So usually non-dialysis patient we can 3 to 4 weekly. All the dialysis patients at least 1 monthly. Right. So that's a entity called two entities. One is a hypo-responsiveness. So we don't assume all the patient one day if we correct all the correctable causes start hypo, then we expect this kind of a increase in hemoglobin. But in some of patients they are not much responsive for hypo. So the hyper-responsive has the powerful. If the patient with the CKD, we start hypo and we expect some hemoglobin rise and maintain, but some people do not respond at all. So that is found to have there is a strong predictor for their cardiovascular events and mortality. If they are not responding to hypo, means the patient's prognosis is quite poor with high risk of cardiovascular mortality. So then, we say this as I told already. So no increase in hemoglobin after with the first month of appropriate weight-based dosing with the good adherent, right? So other than that, so patient with is a hyper-responsive. So if they are not responding, it is not wise to increase the dose, double dose without the weight-based dose. So their prognosis is much poor. Right. So then we have to look for some why the patient is poorly responding ESAs, very important. So first one is very much important, check the adherence is very important, whether they are coming, whether they are doing the weight-based correct dose, adjusted dose, correct frequency and correct adherence. So then we have to correct some correctable, whether they are underlying iron deficiency, underlying B12, so when there is ongoing hemolysis, ACE inhibitors, whether dialysis is okay, whether they are associated with bone mineral diseases, we have to correct all the predictable causes to correct all those conditions, go back and correct these causes if they are not responding. So there's another entity called, so we know that ESA, the term ESA is erythropoietin stimulating agent. So ESA, and we commonly know the word EPO. So there are two entities. One of the EPO is one of the ESAs. There are novel therapies. They will directly stimulate the gene transcription from erythropoietin. So we know that hypoxia inducible factor is important for erythropoietin gene transcription. So there are certain therapies that will stimulate the erythropoietin genes. So that will stimulate endogenous erythropoietin. So other than the erythropoietin production, they can have a high HDL and low LDL effects, include the reduced hepcidin level, ischemia. There are so many other things. So there are certain manufacturers. So other than the EPO alpha, EPO beta, DARBI, there are certain other conditions. Say the Distat, they say Distat, there's a Roxadustat, Vedadustat, right? So Distat, their term. So the important message is they can have some oral. That's a very important, very significant one. So there's most of the time EPO and DARBI we give subcutaneously or intravenously. So these agents can give orally. That's quite significant. And also one of the pharmaceuticals, GlaxoSmithKline, Zydus and all, they are AstraZeneca. So certain manufacturers are on the treatment of Dustat. So that's called PROTECT trial. So they compare this one with the DARBI alpha with the Vadustat. So they can have the stimulating. The very important one is the potential benefits of similar. The hemoglobin concentration bigger, but the problem is still their mortality rate is quite, cardiovascular event rate, hazard ratio. This one is the novel agents has a significantly increase than the DARBI alpha. So then there's a novel other one is SGLT2 inhibitors. So we know the oral iron, IV iron, ESA, there are novel ESAs. Then this is other SGLT2 inhibitors that will shown to be increased. There are recent trials. We know that SGLT2 inhibitors are cardiovascular effective in the renal disease progression. So other than their cardiovascular and renal protection, there is increased hemoglobin in patients with chronic kidney disease. So these are some trials showing there are some benefits in increased hemoglobin. So take away some summary. So the anemia is prevalent around about 60% of non-dialysis CKD patient and 90% of dialysis. The primary cause is reduced EPO production that mainly result in normocytic pneumochronic anemia. So among them, the iron deficiency is very much common, right? Common CKD, most managed through adequate diagnostics. So we do the serum ferritin and TST, so ferrit TST less than 20 with the ferritin less than 200 in hemodialysis, less than 100 in non-dialysis, and tailored iron supplementation as I told earlier, oral versus IV iron. So all patients with if they have adequate iron stores, the serum ferritin level more than 30, transferrin more than 30 and ferritin is less than 500, then they have adequate iron stores. Or then if they are non-dialysis, then they have to individualize the patient with the concomitant comorbidities and how symptomatic the anemia. Should not start iron if the ferritin more than 500 and transferrin saturation more than 30. So ESA therapy is essential. Once if the patient is still anemic, all the potential reversible causes are corrected, then we have to start ESAs. Target hemoglobin is very important. If we start ESA hemoglobin less than 10, followed by with all the corrected all reversible causes. The target hemoglobin is 11.5 to 13, should not go above 13. There's a high risk of cardiovascular events. So we start with the short-acting, long-acting EPO, and there are novel agents like they are orally available, and also the SGLT2 inhibitors are currently on research going in enhancing EPO production. Right, so now, so this is some summary of so far we have discussed. So there are a few other slides more. So there's another case where 65-year-old male with CKD who started EPO with a good weight adjusted rate with a recent good response. They found a recently dropped hemoglobin. So it was quite well, hemoglobin 10, then suddenly dropped to 7. It's like a quick drop. Then but white cell platelets are normal, not any bleeding manifestation. They have hemoglobin LDH normal, but platelet count to be found to be low. So this is kind of a pure red cell case of a place. No, we got it. sorry for the inconvenience, right? So this is a case of I put it like so. This is where the 65-year-old male started on EPO, had a good response and suddenly dropped some hemolysis, but all the hemolytic screening is normal. They found to have a low retic count. EPO hyperresponsiveness is one entity where they do not achieve their target within 1 month of starting the EPO treatment. So then there we have to look for correct adherence and correct weight adjusted dose and all other potential. So this is where patient develop EPO antibodies. So patient has initially responses well and they achieved their target, but they can have potential antibody formation. EPO antibodies should be suspected. They have responded earlier well, but their significant hemoglobin drop with low retic count. So their retic count is low, platelet and white cells are normal, ferritin saturations are fine. So we have to do either we have to look for antibodies or we can do a bone marrow biopsy. So we have to stop EPO and we can start some immunosuppression, cyclosporine and all. So this some unmasking few cases. So anemia in CKD, commonly erythropoietin deficiency, but we look for a cause where the patient is having where we discuss anemic with adequate iron stores. So we know that EPO. Then this is a case where patient started on EPO, but patient suddenly dropped hemoglobin where pure red cell aphasia, since I told earlier. So we have 55-year-old man with the serum creatinine 1.5 renal clinic. So he advised to cut down some proteins. So strictly advised, then found to have a MCV is quite elevated with high, so probably underlying vitamin B12 low, folate deficiency, because that is very common. So we cannot attribute this one to anemia of chronic disease, so CKD related anemia. So always we have to look for high. If the patient is found to have MCV elevated, then go for strictly about their dietary history. So then start some B12 and folate treatment is very important. Then this is another entity where some other case. We have a 65-year-old male who had a significant back pain, referred from local hospital for possible starting EPO. So he's found to have a serum creatinine is 1.2, confirmed ultrasound KUB CKD, hemoglobin 6.5 is significantly elevated ESR. So we know that most of the CKD patients complain variety of symptoms. They have generalized body ache. Very difficult to differentiate a case of some multiple myeloma with the patient with the CKD. So especially very important, and if the hemoglobin drop with the significantly elevated ESR is very important. So we know that elderly patients who are having CKD, they have some related for the age. Myeloma is a very much. So if we attribute this one to CKD and neglect, then patient is ended up in problem. So then we have to properly evaluate with the patient with the proper blood picture, myeloma screening and all. Then we can come to a diagnosis. Then we have a female patient, 37-year-old female with found to be anemic, hemoglobin 8.5. Where ESR also elevated. So this is also, we think the patient is already having a lupus nephritis, quite anemic. Sometimes we might think this patient is already anemic due to CKD. But very importantly, the patient has significantly with normal CRP and high ESR, is having active lupus. So very importantly, this kind of patients always back up of mind to exclude any autoimmune hemolytic anemia is very important. So always this kind of cases, always be vigilant to look for other causes like autoimmune hemolysis. So we have to monitor serial hemoglobins if they are progressively dropping and look for some hemolytic screening to exclude. So this is very important. So other one is 60-year-old farmer with the CKD, already CKD. The farmer presented with the fever, SOB and body aches, found to be elevated CRP, low platelets and chest X-ray bilateral shadow. So this anemia also HB7, sometimes we might think patient already having CKD, so therefore it is acceptable, or we try to give some blood or something corrected, but very importantly just to exclude some pulmonary hemorrhages are very important. So chest X-ray shadows. So monitor serial hemoglobins and see whether there is a hemoglobin dropping in, do possible investigation. So that's in the so few cases. One is febrile illness with the pulmonary hemorrhages. They are already having some already renal involvement. So patient with autoimmune background, especially SLE with lupus nephritis, very important to exclude autoimmune hemolytic anemias, not only the CKD, and also multiple myeloma, even this kind of a patient with some malignancy, prostate malignancy also very important, the male with back pain, high ESR and anemic, so they can have either myeloma or some possible malignancies. And these are very some nutritional problems with the elevated MCVs, so look for some vitamin B12 and all. So directly related to CKDs, absolute iron deficiency is very important. So then hyperresponsive, pure red cell aphasia. So these are some few examples where you can attribute anemia only to CKD, but we might not think some other few causes because of the CKD, but always be vigilant. If we evaluate anemia in CKD, there are still all other causes are possible in every patient with CKD. Right, that's all. Right. Yes. And questions? I think we have so many doctors encounter anemia, CKD every day. So if you have any practical problems or anything, yes. Yes.
Right, so I think we have from this lecture, and for our patients, right? Basically, we have serum
Not available here, yes.
but we can use serum
Yes. Yeah. So if we that's a good suggestion, Dr. Rohit. So when we encounter patients here anemia with a CKD, so decide on categorize them into whether they are pre-dialysis, dialysis, or peritoneal dialysis, then get the potential benefits, whether these are really need for oral or IV iron. So the IV irons, these are the target. You can refer this one at any time in all the textbook and internet. So if until we get this, achieve these targets, monitoring the ferritin level, then we more benefit. And the problem is that will improve the patient's quality of life. That's so important, because most of them are symptomatic anemia. They come with a lot of hospital admission, generalized weakness and all. So if we correctly use IV and correctly use EPO at correct time and monitor, I think we can reduce the number of blood transfusions, right? And we can give them a quality of life and reduce hospital admission, right? Yeah. That's listed. Yes, they are significant. Right. Okay. Thank you. Right. Any other question? Doctors who are working in dialysis unit? Your practical problems and anything? Especially before you encounter any patients with hypo hyperresponsive or any pure red cell or anything?
Another one thing I want to experience also the operation is with anemia, maybe MCV maybe 95.
Yeah.
130 MCV I have seen. So
and also we encourage them not to eat much animal protein because of the high protein diets, and also that will further aggravate that one. Okay, then we'll go for questions. Thank you.
Thank you, sir. I trust this session has improved our knowledge in this area and we can apply this to our daily practice. I would now like to invite Dr. Salinde to speak a few words.
Good afternoon, everyone. It's an honor to stand before you today on behalf of the Clinical Society as we gather to bid farewell to someone very special to us all, our senior consultant physician, Dr. Amarita. Professor, you have been more than just a senior consultant. You have been a foundation of our Clinical Society. It wasn't just about forming a society. We wanted to build a place where we could grow, learn and support each other as doctors. And that's exactly what we did. We have created an environment that has shaped us into better professionals and, more importantly, better people. One thing that always stood out was your leadership. A good teacher doesn't just tell others what to do. They inspire, guide and uplift those around them. You have done that for all of us, whether we were facing difficult cases or navigating challenging times. You were always there to lead with wisdom and calm presence. Your leadership has been a beacon for us and we have all benefited from your guidance. Another remarkable quality of yours is your commitment to keeping up to date with the latest medical knowledge. Medicine, as we know, is constantly changing and it can be tough to stay on top of it all. But we made sure you did, and more impressively, you shared that knowledge with all of us. Through lectures, discussions and everyday conversations, you constantly reminded us of the importance of continuous learning. You made us realize that being a doctor means being a lifelong student. But beyond your expertise, you have been an incredible teacher. It wasn't just about the textbooks or medical facts. You shared your real-world experiences with us, which are often much more valuable. Through these shared experiences, we learned things that books couldn't teach us. You taught us how to handle tough situations, how to stay calm in crisis, and how to always put our patients first. What makes you truly special, though, is your humility. Despite your all accomplishments and vast knowledge, you never acted superior or made anyone feel lesser. You treated everyone with respect, from the most junior staff to the most senior colleagues. It's a rare quality and it's something we all admire in you. However, you are not just a doctor, someone with a passion for traveling and exploring the world. Many of us have had the privilege to hearing your amazing stories, particularly about the time in South Sudan. You shared stories of working in tough conditions in places far from the comforts of home. Yet you faced it all with a positive attitude and a love for the work you were doing. Those stories reminded us that being a doctor is not just about the hospital walls, but using our skills wherever we are needed. As you leave us now, we feel a mix of emotions. On one hand, we are incredibly grateful for all you have done. On the other, we are sad to see you go. Your absence will be felt, but the values you have instilled in us will remain. You have given us the tools to continue the work you started, and for that we will always be thankful. We wish you all success, happiness and fulfillment in this new chapter of your life. We know that whatever life takes you, you will continue to inspire those around you, just as you have inspired us. And thank you for everything, and may your future be as rewarding as the time you have spent with us. Thank you, sir. Thank you all.
I would now like to invite Dr. Kaushal on behalf of the Clinical Society, Base Hospital Mahiyanganaya, to present a token of appreciation. I will now invite Dr. Chaminda to present on behalf of the Government Medical Officers Association Branch Union a token of appreciation. We will now move on to the quiz. Please take a moment to open the participate in the quiz. We would also like to extend our deep gratitude to the sponsors of this event, as well as to all members of the Clinical Society of Base Hospital Mahiyanganaya who have come together to make this event a success. I would like to invite Dr. Prabash Hathurusinghe to present the prize to the winner of the quiz, Dr. Saraswati. I would now like to invite Dr. Lochana Samarasinghe to present a token of appreciation to our speaker of the day, Dr. Prabash Hathurusinghe. Thank you everyone for participating in today's lecture. Thank you to the GMOA Branch Union and the Clinical Society of Research Mahiyanganaya for organizing these sessions, as well as the sponsors. Recording of this lecture as well as all the previous lectures are available on the website csbhm@bb.com. And we hope to see you all at the next session, which will focus on advanced trauma life support and will be presented by Dr. Saman Jayasinghe. This concludes the 11th academic session for the Clinical Society. Please enjoy the refreshments provided. Thank you.
The white background and